Thank you for coming this evening. And my name is Alexis. I'm GP liaison physician at Peter Mac and also a GP. And the presentation tonight is new cancer therapies and voluntary assisted dying. First of all, I'd just like to make an acknowledgement of country. We would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people, and the Wattarung people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just some housekeeping before we get going. All attendees are muted. Please ask questions via the Q&A box only. We will do Q&A at the end of each presentation. The session is being recorded. However, your questions will be asked anonymously to protect your privacy. Please ensure you have joined the session using the same name as your event registration or phone number if you've dialed in. Northwest Melbourne PHN uses Zoom's participant link list to mark attendance, and CPD will not be issued if we cannot confirm your attendance. If you're not sure if your name matches, please send a chat message to Northwest Melbourne PHN Education to identify yourself. So just a bit about Health Pathways. Health Pathways Melbourne provides clinicians with a single website to access clinical and referral pathways and resources at the point of care. Pathways are written by GP clinical editors with support from local GPs, hospital-based specialists, and other subject matter experts. The aim is to provide clear and concise evidence-based medical advice and reduce variation in care, and also to know how to refer to the most appropriate place and what services are available locally. And here are the relevant pathways to tonight's presentation. And as you can see, they are very comprehensive. And here's the one on voluntary assisted dying. So if you would like to join Health Pathways, you go to this website and you click on register now, or you can register via a QR code. Or if you want to find out more detail, you just email this address. And moving on now to the presentations, our speaker tonight for the new and current cancer therapies is Dr. Wei-Li Wong. She is a medical oncologist at the Peter Mac Cancer Centre and Honorary Clinical Research Fellow at the Walter and Eliza Hall Institute. Her areas of expertise are gastrointestinal cancers and cancers of unknown primary, CUP. Her research focus is on the use of real-world data to examine treatment and outcomes in routine practice, facilitate research, and improve the quality of care for patients. Over the past 10 years, she has been involved in running a large multi-centre registry collecting comprehensive treatment and outcome data for colorectal cancer. She also led the implementation of the registry-based randomised trials programme, part of the VCCC's research initiative, examining the feasibility of this pragmatic clinical trial approach to increase trial participation for cancer patients. She is currently part of a team of investigators working on a new model of care to support the earlier diagnosis of cancers of unknown primary. And our second speaker tonight, who's talking about voluntary assisted dying, is Susan Jury, who's the Victorian statewide VAD Navigator Service Manager. This service provides information and support to anyone impacted by voluntary assisted dying, individuals, families, clinicians, and health services, supportive and non-supportive. Susan is a clinical nurse consultant with an extensive health program development background and a master's degree in public health. So I would just like to hand over to Wei-Li, who will be talking about our overview of current cancer therapies. Thank you.
Thank you so much, Alexis. I hope everyone can hear me all right and can see my screen. So thank you so much for the introduction, and thank you also for the invitation to speak tonight. I really really enjoy actually giving these talks and engaging with the community, and am very grateful to everyone involved in primary care for the hard work that you guys do in taking care of our patients. So I'm going to talk tonight about just an overview about our current and some of the new cancer therapies that we're using. And the aim, let me try and advance my slide. Okay, there we go. So the learning objectives for my talk are to describe different types of cancer therapies that we use in current practice, to understand how biomarkers may impact on prognosis and treatment selection, and to recognize some common side effects that occur, especially with these new targeted therapies and immunotherapy. So I actually want to start off with a story, and this is one of my patients that I will remember forever. He is a 38-year-old man who was previously well, and he presented with hematuria and was found to be in DIC essentially, and had to be admitted to intensive care for blood product support. And he needed over 300 blood products at that time. He had some imaging that showed that his liver was almost completely infiltrated, and he had nodal disease in the upper abdomen, mediastinum, and the neck. So very suspicious for cancer, but with no obvious primary tumor seen. And then he had a cervical lymph node biopsy that showed a metastatic adenocarcinoma with an immunohistochemistry profile that was positive for TTF1 and MAPSIN A. So these are typical lung markers, but not necessarily specific in that they can also be present in other tumor types as well. So at this time when I saw him, he was still in ICU and very unwell. And to give him this diagnosis of an advanced cancer of unknown primary with a very poor prognosis, and basically had to tell him that we would try some systemic therapy, but the chance of response would be about 10 or 20%. We would need to see if that would be able to shut off his DIC, because he was still actively bleeding at the time. And everything was really quite dire and depressing. But then the next day, I got a phone call from our pathologist, and he had done some additional immunohistochemistry stains. And that showed strong staining for this ALK protein, and that's usually a product of a fusion between two genes called EML4 and ALK. And the importance here was that it's a recognized cancer driver, particularly in lung cancers, and there's a treatment and effective treatment for it. So this guy was started on alectinib, which is an oral ALK inhibitor. And these are his scans. So if you look at the color images, that was about a week before he started treatment, where you can see that his liver is almost completely infiltrated. And 8 days after starting that, he had a complete metabolic response. And he got discharged from hospital within 2 weeks of him starting treatment. And this was a guy who, at the time that he had a cervical lymph node biopsy, was told that if he had a bleed from that, there would be about a 50% chance of mortality. And that was 4 years ago. And, at the time that he got diagnosed in October, all that he wanted was to make it to his son's birthday in December. And that was 4 years ago. And so this case really highlights to me how much the treatment landscape in oncology has changed and is continuing to change, and how lucky we are to be able to have these stories and have these drugs that are available to use. So broadly speaking, when we think about cancer therapies, we usually say that the pillars of cancer therapies are surgery, radiotherapy, and then systemic therapies. And then the systemic therapies, we usually divide into traditional chemotherapy, targeted therapy, or precision therapy. And I would include hormonal therapy as one of those as well, and then immunotherapy. And we actually do have new and emerging treatments. For example, theranostics, which is a combination of the word therapy and diagnostics, where it's predominantly run by a nuclear medicine or PET team, where there's usually a radioactive molecule that's attached to the diagnostic marker. And so we are already seeing this used in real world practice, for example, PRRT in neuroendocrine tumors, and lutetium PSMA in prostate cancers. And then aside from radiotherapy, we also have other types of local regional therapy. So that might be microwave ablation or SIRT, which is sort of internalized radiotherapy to the liver. But the focus on the talk today really is systemic therapy. So when we are choosing treatment, aside from looking at the patient factors and what they're fit for, a major consideration is what the aim of systemic therapy is. So sometimes systemic therapy in itself might be definitive or curative treatment. Most commonly in hematological malignancies, such as leukemia or lymphoma. But some solid tumors are very chemosensitive, such as germ cell tumors. And so in this situation, the systemic therapy is the definitive treatment. We also use it in the neoadjuvant or adjuvant setting. So neoadjuvant or before surgery, where the aim is to downstage the disease and to improve surgical outcomes. And then when systemic therapy is given after surgery, the aim is to eradicate micrometastatic disease and to improve survival. And then in disease that's not potentially curable, where we're using treatment for a palliative or a non-curative intent, then usually the aim is to prolong survival, improve disease symptoms, and improve quality of life. And one of the things that is that I think is becoming more evident these days is that stage 4 disease is not always incurable. That sometimes, and we often use multimodality treatments. We might use a combination of systemic therapy to downstage someone and get them either to surgery or local regional therapies, or in some tumor types where the availability or the discovery of biomarkers or new treatments are rendering some patients with prolonged disease control compared to before these treatments were available. So the second consideration, and this is tumor specific, are there any biomarkers that predict for treatment response or resistance? And so these biomarkers are usually specific to that tumor type. So for example, in breast cancer, whether or not that's a hormone receptor positive breast cancer or HER2 positive breast cancer. And some biomarkers are present across multiple tumor types. So we call that tumor agnostic. So for example, mismatch repair deficiency predicts for immunotherapy response regardless of the primary tumor site. Sometimes the same biomarker targeted therapy can have a different response across different tumor types. So for example, BRAF mutations are present in melanoma as well as in colorectal cancer, but when the drugs were initially developed, the response rates were much higher in melanoma compared to colorectal cancer. And that's probably due to crosstalk between different cancer pathways that are seen differentially according to different cancers. And there are different methods to identify these biomarkers. And so immunohistochemistry is probably the simplest, where that can be initiated by a pathologist after they do the initial morphology and diagnostics. Then they would cut additional slides to look for particular protein expression. And so the ones that are commonly used at the moment are mismatch repair, ALK or PD-L1, HER2, estrogen receptor, progesterone receptor. So those are quite common and standard tests that are done and that are often initiated by the pathologist when they're doing diagnostic work. And then according to the tumor type, there may be limited gene mutation panels that are specific to that cancer type. So again, this might be initiated by the pathologist or requested by the oncologist when we're seeing them. So in melanoma, looking for BRAF mutations is important. In lung cancer, EGFR mutations, and then in colorectal cancer, looking for KRAS mutations. And then the last one in terms of more extended sequencing. So this is where we're looking at a broader gene panel where it might be something like 500 to 600 common cancer genes, or even whole genome sequencing or RNA sequencing. And here we're really looking at rare alterations, things like tumor mutation burden. And so this is where it might be in patients where they don't already have an identified common marker, but we're looking from a bit more exploratory point of view to see if there may be anything targetable. And so with each of these different methods, the cost increases, the complexity of testing increases, and the turnaround time increases as well. So for example, in that case that I described, we were quite lucky in that ALK fusion was identified on IHC, which gave us a result the next day. If we were to look at doing some extended testing to look for rarer mutations, that testing might have taken about 5 or 6 weeks to return. And so often we are needing to start some kind of systemic therapy or empiric systemic therapy while we're waiting for results of that sequencing to come back. So just briefly about traditional chemotherapy. So this was actually an accidental discovery during World War II, and the first study of nitrogen mustard in lymphoma was published in 1946. And broadly speaking, there are many different classes of drugs, but they all work by disrupting the cell cycle in some way. And we often use drugs in combination with the aim to increase efficacy while limiting toxicity and trying to suppress drug resistance. And the principles behind combination chemotherapy are to use drugs with ideally synergistic mechanisms of action, to use drugs with different dose-limiting toxicities and resistance patterns, and to try and keep the treatment-free interval to a minimum. The main feature that results in a relative selectivity for cancer cells over non-cancer cells is the more rapid turnover, which also means that chemotherapy tends to be most effective in rapidly dividing cancers. But both cancer and non-cancer cells are affected, and that is often the cause of the common toxicities, particularly mucositis or the GI toxicities, alopecia, and the hematological toxicities. And so we can think about chemotherapy toxicities according to timing. So that immediate toxicities, which can happen minutes to hours after administration of chemotherapy. So things that can happen in the chair while patients are getting their infusions. Early toxicities, which happen days to weeks after the administration of chemotherapy. And then late or delayed toxicities, which can happen months to years after administration of chemotherapy. So immediate things might be things like toxicities might be things like hypersensitivity reactions, nausea or vomiting. Early toxicities, quite commonly GI toxicities, fatigue and anorexia, cytopenias, as well as myalgia. And then late toxicities, we think about infertility, early menopause or secondary cancers. So moving on to targeted therapies. So these are treatments that aim to target a specific mechanism of cancer pathogenesis. And so the earliest form of targeted therapy that I think of is endocrine therapy for breast cancer. And we've been using tamoxifen since the 1960s. And of course, there are a lot of new types of endocrine therapies, both for breast cancer as well as prostate cancer. And this really is a rapidly growing field as molecular targets continue to be identified. So these two scientists, Weinberg and Hanahan, they initially described these 6 different pathways that are called that they called the hallmarks of cancer, and basically describe all the different mechanisms that that cancer cells use to both proliferate and metastasize. And so there are things in green here, such as sustained proliferative signaling. So there's all these growth pathways that are involved. There's the induction of angiogenesis. And they first described this about 20 years ago. And in that time, there have been more discoveries and more pathways, where now in the updated figure last year, you can see that there are additional hallmarks such as avoiding immune destruction, genomic instability, and some of these hallmarks already have established treatments to target these pathways. Some of them have emerging or developing therapies, and then on top of that, there are further emerging hallmarks that have been identified and are being worked on as well. And so broadly speaking, the targeted therapies tend to either be monoclonal antibodies, and usually the naming nomenclature are drugs that end with MAB. So these tend to work externally by preventing ligand receptor binding and then induce immune-related cytotoxicity, or can be used to localize another agent. So for example, having an antibody bind to the receptor, but the antibody actually being a carrier of chemotherapy. So like an antibody drug conduit would be an example as well. And then tyrosine kinase inhibitors. So these monoclonal antibodies are essentially all intravenous. And then tyrosine kinase inhibitors tend to be oral. And then the naming would be drugs that end with NIB. And these tend to work internally, and they target the receptor tyrosine kinases within the cell to try and reduce the activation processes inside the cell. And often these drugs have multiple targets, so we call them dirty drugs. And regardless of whether or not it's a mAb or a NIM, the side effects often relate to the pathway being inhibited. So you would get the same side effects irrespective of the type of drug that's being used. And just to give you an example of the absolute explosion in these treatments and the types of treatments that we're using is that this is just an example of different tumor types, different targets and drugs that are being used. So in breast cancer, for example, for a long, it's well established in terms of the hormonal therapies being used, such as tamoxifen and letrozole. There are drugs that target HER2 amplification and CDK4/6 inhibitors, which work on the cell cycle. Particularly in lung, there has been a major change even in the last 5 to 10 years of these targets and drugs that are available. So ALK fusions, EGFR mutations, KRAS mutations, which have not been druggable for a very long time. One thing you can see is that there are some targets that cross tumor types. So HER2 amplification is most common in breast cancer, but is also seen in gastric cancers, and both are targetable. And there are some where, and so usually with these, you need to identify the biomarker on the tumor cell in order to use the drug. But there are some targeted therapies that work broadly. Say, for example, the bottom one with bevacizumab, which is a VEGF or angiogenesis inhibitor. This doesn't require a specific biomarker to find a mutation or amplification in that. It just broadly works in terms of angiogenesis. And then with kidney cancers, there are multiple oral drugs that are being used as receptor kinase inhibitors that target multiple receptors at one go. And there's actually many other drugs in development as well across other tumor types. So moving on to immunotherapy. So Dan Chen is an oncologist in the US who described this, and I thought was quite a good description of what immunotherapy is all about, and basically said that cancer uses a sort of cellular camouflage that tricks the immune system into seeing it as a normal cell. And so cancer immunotherapy seeks to strip away that camouflage. And so him and Ira Melman had described what's called the cancer immunity cycle, which is a complex pathway, but it essentially shows that this mechanism of the cancer cell releasing antigens that are then presented to the immune system, which then gets activated and then infiltrates the tumors to result in cell killing. And all the green are the stimulatory factors that support this cancer immunity cycle, and the red are the inhibitors. And this balance between stimulatory and inhibitory factors are those that result in tumor cells either surviving or not surviving. And so we think of this more simplistically in terms of the 3 A's. So antigens, access, and activity, in terms of why immunotherapy might work in a particular cancer type or patient compared to a different scenario. So antigens essentially meaning that there has to be enough foreign antigen or cancer cell antigen to be presented to the immune system so that it can be recognized as being foreign. And then in terms of access, that the tumor cells need to be able to get access into the tumor. So some situations such as very dense stromal tumors where T cells are less able to access tumors and drugs, that may be a reason why immunotherapy may be less successful. And then activity. So the T cells that actually do gain access to the tumor need to actually be able to have activity. And when we think about immunotherapy in solid tumors, generally speaking, we're talking about immune checkpoint inhibitors. So there's a lot of different types of immunotherapy, different things that are used in hematology, but we think broadly around immune checkpoint inhibitors. And so the commonest drugs that we use are a CTLA-4 inhibitor called ipilimumab that basically acts during the priming phase to remove the inhibitory signal between the dendritic cell, which is presenting the tumor antigen to the T cell. And then the other drugs that we use are anti-PD-1 inhibitors and anti-PD-L1 inhibitors. And these work in the effector phase where the T cells are coming towards the cancer cell, where again, these are receptors and ligands that negatively regulate that, that interaction. And these antibodies are sort of removing the brakes off that interaction. And so there are lots of drugs both against PD-1 as well as PD-L1. In terms of immunotherapy, so we use a lot of immunotherapy now across more cancer types, but there are still cancer types in which immunotherapy has not been shown to be effective. And so this was a modeling exercise to look at why some tumors are more likely to respond than other tumors. And basically, this comes back to that antigen question, where the higher number of mutations the cancer has, so that tumor mutation burden, the more that seems to correlate with the response to treatment. So on the right side of the scale, you can see tumors like cutaneous squamous cell cancers, melanomas, and these mismatch repair deficient cancers, which have very high tumor mutation burden, seem to have a better response to these agents. And here, for example, pancreas cancers, which are considered cold tumors or low tumor mutation burden and very heavily stromal tumors, where immunotherapy is still not effective. And to give you an idea, immunotherapy has been an absolute game changer in melanoma. And so this was one of the early studies in immunotherapy now, which was examining the combination of nivolumab and ipilimumab, which is a PD-1 inhibitor and a CTLA-4 inhibitor. So the green line being the combination, and you can see that on the x-axis, that's 60 months. So at 5 years, half of the patients who had this treatment are still alive. And even with the single agent PD-1 itself, it's 44% or even 25% with single agent CTLA-4. And before immunotherapy, the median survival for melanoma was 8 months. So that's sitting somewhere around here. So it's absolutely changed both prognosis as well as the treatment in melanoma, and increasingly other tumor types as well. So of course, with great efficacy also comes toxicity, and immunotherapy toxicities tend to relate to autoimmune side effects. Ultimately, any organ system can be affected, and these can occur at any time point, including after immunotherapy has ceased. The exact mechanisms of immune-related adverse events are poorly understood, but are generally felt to be mediated by T cells, B cells, as well as cytokines. And what we see here is that the more treatment you get, the more toxicity, fairly similarly to chemotherapy. So this was again that study where, with the combination of nivolumab and ipilimumab in melanoma, almost 100% of patients had any grade, so any severity of side effects. So almost all of them would have some kind of side effect, and almost 60% of them would have a grade 3 or 4 toxicity. So that's a toxicity that's severe enough to warrant a hospital admission. And these rates are much lower with the single agent therapies, but are still around 20% or so. And in the combination, there were few death rates, but they do occur. But about 30% of patients would have a severe enough adverse event that would lead to discontinuation of treatment. So usually when I consent a patient to immunotherapy, the things that I tell them about are that most of the time it's well tolerated when patients actually come to receive treatment. That there's very few immediate side effects, the most common being a fever, some fatigue, and a rash. But then in terms of toxicities, I tell them that there are some toxicities that may be mild or manageable, in that they can continue their immunotherapy, have management of their toxicity, which may involve either low-dose steroids or, for example, with the endocrinopathies, just replacement of their replacement of whatever hormone they are deficient in. And then there are some toxicities that are a bit more serious, and the examples of those would be colitis, pneumonitis, and hepatitis, where it actually would warrant a stop in treatment, potentially a hospital admission, and certainly higher dose steroids or immune suppressants to actually treat those toxicities. And then the third group of toxicities are the very rare ones, which have been, sort of case reports in literature, rare but can affect any organ system. And importantly, telling them that, toxicity can either be life-threatening or life-altering. So for example, patients with unusual neuropathies, like say, a patient who might just have a sixth nerve palsy, which is immune related, but then results in double vision and never being able to drive. So those might be a rare toxicity, but still can be quite life altering. So here, this first page are the toxicities that are the more common ones that are well recognized that we frequently look out for. So GI toxicities such as colitis, we look for diarrhea, so a more watery stool or increased frequency of bowel movements, abdominal pain, blood and stool, or constitutional symptoms. With hepatitis, it's mainly elevations in liver function tests, which may or may not come with other clinical symptoms. So we do check liver function tests at baseline and prior to each infusion. Skin toxicities, often patients will report an itch with or without a rash. And then in terms of pneumonitis, could be a cough, which is new or worsening, shortness of breath, fever, or chest pain. And then other toxicities in terms of endocrine. So thyroid function tests and cortisol levels are checked regularly, but also symptoms might be things like vague symptoms, often like headache, fatigue, visual field changes, any neurological toxicities such as motor sensory neuropathies, and other uncommon adverse events, but that have been reported, including uveitis, vasculitis, nephritis, so renal function going off as well. This is just to show that the timing of the toxicity and the type of toxicity can depend on the agent. So ipilimumab, being a CTLA-4 inhibitor, tends to cause more colitis, and that's partly because of the higher expression of CTLA-4 in the bowel. And conversely, with higher expression of PD-L1 in the lungs, there's more pneumonitis with the anti-PD-1 or anti-PD-L1 therapy. So here you can see that usually the duration of onset tends to happen within the first 3 months or so of treatment, but can really happen at any time. The general principles of management are that we perform baseline investigations and then routinely monitor and bloods, including thyroid function tests. And upon presentation, prompt diagnostic investigations should be performed to rule out other etiologies, but we often initiate treatment for immune-related adverse events anyway, as clinically appropriate if there's a high suspicion. And often management of these toxicities requires a multidisciplinary team of advanced clinicians. And so when we think about a patient reporting some adverse event, broadly speaking, we think about could this be cancer related? For example, if they have abdominal pain and they have known intra-abdominal disease, could it be because of disease progression? So is it cancer related, treatment related, or completely unrelated? So for example, with diarrhea, we're wondering about immune related colitis, but some patients also get concurrent viral gastro, for example. And then also broadly, the way these are managed depends on the severity of symptoms. And so mild toxicities are usually treated symptomatically. If they persist or become more severe, then they can be treated with oral steroids as the first line of therapy, and often holding drug until they improve. And then worsening symptoms or symptoms that are severe or life-threatening will warrant a hospital admission for intravenous steroids, and then alternative immunosuppressive therapies. And at each step along the way, including when patients start off with mild toxicities, to increase monitoring, ruling out non-immune related causes, and then looking at individual management guidelines for specific toxicities. So I thought hopefully I have enough time, Alexis, to go through. I think I've got 2 or 3 cases to stop there.
Yes, I think so, because Susan's got to come on at 7:40. We want to allow a few minutes for questions. So
no worries.
Just one of the questions is, can you describe a bit more what a solid tumour is actually referring to?
So when we say solid tumor, we basically say things that oncologists treat rather than hematologists. So hematologists tend to treat leukemias and lymphomas, and so everything else really is a solid tumor. So I guess a more solid organ tumor rather than a blood-based cancer is what I mean.
And then there's another question, is immunotherapy being used earlier and earlier in the treatment paradigm? Do you see it replacing more traditional treatments?
Yeah, I think we've, since we started using immunotherapy in the early 2010s, I think the indications have certainly expanded to more tumor types. So it was initially only used in melanoma and then expanded to lung, renal. And so more and more tumor types are having indications with studies coming out. And also earlier in the treatment course, in that they might be used in the neoadjuvant setting or as definitive treatment or even adjuvantly as well. I think that, if we think back about that modeling graph to look at the tumor mutation burden, there are still some tumor types that seem very cold, where some, say for example, pancreas cancers, there have been a whole lot of studies looking at immune checkpoint inhibitors in pancreatic cancer that have not yet been successful. And there are studies that are ongoing to look at different types of immunomodulatory approaches. So combining a checkpoint inhibitor with a different type of pathway inhibitor or agonist. It's hard to know whether it will eventually, I don't think it will completely replace traditional chemotherapy in all tumor types. There are some cases now where we are using immunotherapy in combination with chemotherapy to get a better response. So it's probably still few tumor types that respond only to immunotherapy without also chemotherapy.
And can I also ask, with targeted therapy, am I right in thinking they end up rotating through therapies, they develop resistance, and then they have to go on to another one, and then eventually, sadly, you sometimes run out of therapies. Is that the right way it works, or is that?
Yeah, I guess with any of the systemic therapies and in stage 4 disease in general, and same for chemo, is that the general principles are that patients will start off on a type of systemic therapy and they may get an initial response. They may get a long duration of response or a short duration of response, but eventually tumor resistance will eventually develop. And then when that happens, you switch to a different form of systemic therapy. With targeted therapies, the mechanisms of resistance, I guess, are a bit easier to study in targeted therapies. So for example, in lung cancer or EGFR mutated lung cancer, when the initial drugs were developed, like erlotinib and gefitinib, patients would start on them, they would develop resistance. And then there were all these studies looking at doing rebiopsies or blood tests at the time to look for why they had developed resistance, had they developed a new mutation. And so what was found was that a common mechanism of resistance was this mutation also in EGFR, but called T790M. And so the new generation of EGFR targeted therapies were designed to inhibit the T790M mutation, so osimertinib. So that is now being used in first line to sort of overcome that at the start or at the time of resistance. So you're right in that, at each time, it kind of depends on the mechanism of resistance. And if it's a mechanism that can be overcome by still applying that targeted therapy, then you would do that. Otherwise, if they're resistant to targeted therapy or that pathway, then you might have to switch to chemotherapy or immunotherapy.
Okay, thank you. Thanks very much, Wei-Li, for simplifying, an area that I find really confusing. And that was great. Thank you very much. And I'd like to hand over now to Susan Jury, who's going to talk about voluntary assisted dying. Thank you. Thanks, Wei-Li.
Here I am. Thank you. Thank you, Kwon, Alexis, and PHN for inviting me along this evening to have a chat about voluntary assisted dying. So It's just a brief kind of chat this evening, and I thought I'd cover, just to start off, just some of the top 3 things that GPs might like to know. And I guess I also acknowledge that in this room, there's going to be a wide range of experience. There's definitely at least 1 or 2 names that I recognise who are involved in voluntary assisted dying, so hello to you. But all of you, thanks for taking the time just to get a little bit of awareness of it if you aren't already. One of the first things that might be the most useful to know is that whenever someone actually raises VAD with you, that's always a time when you can refer them through to us. If you don't know who we are, the Navigator Service is a, we're Victoria, Craig, we're across Victoria. We're based in Melbourne, but we have navigators across regional Victoria as well. We're senior nurses, social workers and psychologists in the team, and we're here to help patients, families, doctors, get doctors and absolutely anybody where VAD impacts on them. So if someone raises VAD, you can have the chat with them, refer them on to us, and even if you don't think that the person's eligible, or maybe they're not eligible yet, it's always can be quite helpful for us to have a bit of a chat with them and talk through them about what's involved. Now, you might already know that in Victoria, all clinicians legally, this is including doctors, cannot raise or suggest VAD to their patient. This is different to some other states in Australia, but what it does mean, we'll talk about it a bit more in a minute, but once it's been raised by the person, then it's okay to talk about it. And this can cause a fair amount of angst amongst all clinicians at times. And by the way, if you have questions or comments, please feel free to put it in the Q&A because I'm keeping a bit of an eye on it at the time and it will help me guide what I talk about. And then the third tip is that you can be involved, or any clinician at all can be involved to the level that you feel comfortable. I've got a pyramid I'll show you in a minute, but it ranges from, by law, it's quite within anybody's legal rights to say, I'm sorry, I'm not the person to speak to, you're going to have to speak to somebody else. So absolutely no conversation whatsoever about voluntary assisted dying, up to a hierarchy, up to actually doing the training and being prepared to administer the drug. So finding a place of comfort for you is good. So then very briefly, to access VAD, and I'm sorry for some of you who will be very aware of this eligibility, but in Victoria, the person needs to be an adult. Now, they must be towards the end of a terminal illness, okay? So they must have a defined terminal illness. And I note in the considerations, for example, there that an elderly person who is got general frailty, but no defined terminal illness, there's every reasonable likelihood they wouldn't be eligible to access VAD. There's many people who might be suffering, having chronic pain and so on, but unless they've got that terminal illness, they're not going to be found eligible. The person needs to be able to make their own choices right throughout. And this is quite relevant when people are towards the end of life and maybe losing or coming in and out of consciousness as they come towards the end of life. They need to be able to ask right up until the very end, until the day that they actually either take the drug themselves or have it administered by a doctor. And they must be an Australian citizen or permanent resident. This can be a bit tricky to prove sometimes for some of our, what we call our 10-pound POMs, or sometimes our Kiwis who've been living here for a long time, or immigrants after the war, where they've lived here their whole lives, vote, get all other healthcare, but may have difficulty proving eligibility to access this. And they need to be living in Victoria for the last 12 months, which was a safeguard to prevent the risk of medical tourism in the early days. The considerations I note here, in addition to what I've already spoken to, is some of the timeframes that this can take around about, depending on a few factors, but around about 4 to 5 weeks to get through the assessment process. And so what this means is that it's much better for a person to undergo assessments for VAD as close to the eligibility time as possible, which is 6 months for most conditions, or 12 months for a neurodegenerative illness. And getting that assessment done early is can alleviate stress around accessing assessments and so on, and it can also remove the focus towards the very end of life. Discussing VAD, as I mentioned, cannot be raised, but once a person has raised VAD with your team, like for example, a person raises it with one of your colleagues, then it's okay to then discuss it with the person. Of course, treading carefully that you are not seen. You can see here the exact wording in the legislation, that you are in substance not suggesting voluntary assisted dying to that person. If it's already been raised by them, then the conversation can proceed. Sometimes they might raise it with another healthcare professional, and then they would come to, like in a hospital setting, for example, they might raise it with a bedside nurse who might then refer them to either to us or to the treating doctor, who may then go to the patient and say, I believe you want to talk to me about your end-of-life options, something like that. So there's just a very quick slide on responding if somebody asks about voluntary assisted dying. All clinicians tell us often that they're scared of talking about it. They don't know what to say. They don't know how to respond to the person. And often from the person's perspective, when they get to us, they say they've asked so many times before they get to us. And this can really add a real stress to them. And sometimes what it means is that by the time they actually start the process, it's too late, and it can actually become more distressing potentially. As mentioned, you don't have to participate in any way at all if you don't want to. And that's legislated in Victoria. Just to show you here, when doctors say that they are participating or not participating in VAD, we often think it's not quite so linear or black and white as that. Because it can range, it can vary, and it can vary by patient, or it can vary by what's going on in the doctor's life or the patient or their condition, what you might feel comfortable with. And participating at some level might be providing some information to the person, or providing contact details to them, providing our contact details to them. Ranging up to providing general clinic, like for example, one of your patients asks for assessment for VAD. They may then come to us, and we might contact you and ask for some information on what you think the person's prognosis might be. We might ask you for a bit of clinical information, or we might ask you if there's any concerns or risk factors for this person that would be important for an assessing doctor to know. And up to when, for doctors to be involved in actually assessing a person's eligibility for VAD, they need to have done, the doctor needs to do training, and I'll talk to you in a minute about where that training is. As an assessing doctor, you may choose to be what we call coordinating doctor, which does involve then writing the script for the drug, or you could be a consulting doctor, and that means doing one assessment only, and that's the end of it. And so, as I say, it really depends on where each individual's comfort levels sit. There's a question that came up in the chat from Jacques, hello, and it's about putting any issue with mentioning VAD on the practice website or waiting room information. And some GP practices do actually put this on their website, and they say, we offer voluntary assisted dying. And we were asked only a few days ago about whether it was acceptable to have information in the waiting room, and even some of our faith-based organisations do have in their end-of-life choices brochures. As part of their end-of-life options, they do mention voluntary assisted dying, and then based on the organisation's position, it might say, here's the navigator's details to get some more information. So you're not in substance suggesting VAD to an individual patient as part of your care, so it's not considered a breach of the legislation to have that generic general information available. I hope that answers your question. The other thing that comes up is about this first request. Now, there's different types of first request. Now, when there's a legal first request. And if a person is asking a VAD assessing doctor and saying, please assess me for voluntary assisted dying, that would be what we call a first request. Now, there's legislated timelines around that, meaning, for example, the doctor must respond within 7 days to say, yes, I'm happy to be your assessing doctor. And that becomes documented in the portal as part of the assessment process. But if a person asks you about VAD and they want some more information, if they're just asking for general information, that's not what is generally considered, that's not considered the first request. We would always anticipate a response to that, but it won't be part of the assessment process. And often what we find is that by the time the person gets to this legal first request with a VAD assessing doctor, they've actually asked many times. They've asked their usual doctor, they've asked their usual GP, their usual oncologist. They've asked a number of different people before they get to that legal first request. But of course, sometimes asking about VAD can be, people tell us it can be the most difficult thing they've ever had to ask for in their life. And it can be an incredibly difficult thing for them to raise, not only because they're facing their mortality and a whole lot of conflict and fear around that, but also not knowing how the doctor or the nurse or how the person might respond to their request. So it does open a conversation, opportunity for conversation. And as I mentioned before, we'd always encourage to provide our details regardless to the person who might raise it with you. Just checking the time. Okay, we've got 8 more minutes. So the type of information that you might provide a person if they ask about VAD, as a minimum, always ask them what they would like to do next. That might be absolutely nothing. It might be, no, that's okay. I just wanted to discuss it with you, and that's the end of it. But sometimes people think that because they've raised it with their GP, they're on the program. And then they come to us months and months later thinking that they're on the program and say, no, I've spoken to my GP and they said that helped me and it's all good and it's all done. And in fact, that's far from the case, which can be stressful for everybody. And we also, the other thing we would encourage is, this isn't mandated, but we would encourage, if you do know a doctor who's done the VAD training, by all means ask that doctor themselves if they'd be willing to see this person, but ask them first before you refer the patient. The reason being is that sometimes patients, for example, it may be that they are going to need practitioner administration. For example, a person with motor neuron disease who's not able to swallow, or a person who has bowel obstructions from cancer, they're going to have prac admin, and not all doctors are willing to do that. And we don't want to see them feeling pressurized into doing that. So ask the doctor first, and then or by all means give our details, and we'll match the doctor carefully to the person. So we'll consider, is practitioner administration likely? Do they need a home visit potentially, etc., etc. And it can be helpful, even if it's very clear to you that this person is not going to be eligible. Sometimes we find it's helpful for them to speak with people who they know are supportive of VAD, so that they don't feel any risk of potential obstruction or that they're not being listened to in their request. And assisted dying can always be in parallel with other treatment options. So we would never say that it's one or the other, or that, no, you're not going to need VAD, because it could be that a person just wants it in their back pocket, an insurance policy, and they could be still, absolutely would encourage them always to be receiving palliative care. They could be on other treatment trials, etc. So just to nearly wrap, is that if you're thinking about becoming a VAD assessing doctor at any point, one thing I would always suggest is, if you know another doctor who is doing this, speak to them, ask them what it's like for them. Know that you'll be part of a community. We provide lots of support to involved doctors, and especially the first few times that they're involved in assessments. We're often with doctors when they do their first few assessments, certainly if they do administer the drug. There's a medical community of practice where doctors come together to share their experiences, and we really work to protect doctors' confidentiality. And it's entirely, doing the training doesn't mean to say you're going to be bombarded with patients, because it might be that you do the training only ever for your own patients, which is completely fair and reasonable. The training is online, or we have 2 training days that we run, which doctors much prefer, because they get together and they get it done within the day. Those details are publicly available, so feel free to keep them. They'll be in the slide pack that Alexis and Kwan will send to you. You can give those numbers to your patients, or you can call us yourself at any time. And that's the end. I think I'm on time. Thank you, Alexis.
Thanks. Just one question here, Susan. We've got time for one question. Are there ever exemptions to the permanent residency requirement? And I know what you're saying, so these people on 410 visas, for instance, who've been living in Australia for years and they're quite elderly, does it have to be very strictly?
Everything about it is bureaucratically very stringent, and it's to protect the program and to be really sure that everything is adhered to. If you have a patient who's on a 410 visa or on visas and you're worried about it, the best recommendation I would say is get in contact with us sooner rather than later, because we would look on Vivo, which is the online immigration website. And we might need to help the family to get proof from the Department of Immigration. Often it can be shown through a stamp in the passport, but no, it's pretty strict actually, Alexis.
Oh, okay. Thank you.
Yeah.
Thank you very much, Susan. That was great, very helpful. I'm just going to wrap up with a couple of things that might be useful. Parkville Connect, I don't know if you've heard of it, it's a web-based portal for GPs. You can have access to your patient's medical record. That's either the Royal Melbourne, the Women's, or the Royal Children's, or Peter Mac. It doesn't replace the usual point-to-point correspondence, and of course your patient has to provide consent. In order to be able to do this, you register your practice, and you also have to be listed on the National Health Services Directory. And if you do all these things, you can have access to things like hospital visits, progress notes, discharge summaries, and results. That can be very useful. The next thing I'd just like to mention is that there's a clinical placement program being run by the Cancer Survivorship Group, mainly for allied health and practice, particularly practice nurses. They'd really like to see practice nurses to upskill them in nurse-led survivorship care. So it would help them learn how to incorporate survivorship into care plans, maybe teach about vaccination and appropriate recalls. And this is our next upcoming webinar on the 26th of July. Declan's going to be talking about prostate and other urological cancers. We haven't quite nutted out the details yet, but we will email you with the details of this if you give us your email address, which we ask for on the evaluation if you're interested in hearing more about our education program. And also at this evening, Janelle will be talking about improving cancer patients' nutrition, how that can actually improve their cancer outcomes. And just lastly, you will get an email within a week, which includes the slides and resources, and your CPD will be uploaded within 30 days. You can see further education sessions on this website address, and the session is going to be recorded, so you can go back and have a look at it. And please give us some feedback. And with that, I'd like to thank our speakers very much. So thanks a lot to Whaley, who took on that huge, complicated topic, which I think is really difficult to get across to GPs. And thank you also to Susan for a very comprehensive talk about voluntary assisted dying. And also many thanks to our helpers from the Northwest Melbourne PHN, Yvonne and Vanessa, and also thanks to Kwan Nguyen from Peter Mac, who's our medical education officer. And thank you all for attending tonight. Thank you.